Hello and welcome to the topic bipolar disorder in the psychiatry module. By the end of this topic, you should be able to define bipolar disorder, explain the types of bipolar disorder, discuss the pathophysiology and causes of bipolar disorders, understand the clinical manifestations of bipolar disorders, describe the investigations and assessment for diagnosis of bipolar disorders, and discuss the management approach of bipolar disorders. Let's get started. Bipolar disorder, previously known as manic depression, is a mental disorder that causes periods of depression and periods of abnormally elevated mood. The altered mood is significant and is known as mania or hypomania, depending on its severity or whether symptoms of psychosis are present. Bipolar disorder is characterized by periods of deep, prolonged, and profound depression that alternate with periods of an excessively elevated or irritable mood known as mania. Bipolar is a condition that affects the brain and is characterized by erratic mood changes which can affect the energy and activity levels daily. Here are 4 types of bipolar disorder and how they are characterized. We have bipolar type 1. This type of bipolar disorder is characterized by manic episodes with or without depression symptoms. If one has this type of bipolar, the manic episodes will last a week or longer. Mania may be so bad that it requires one to be hospitalized to ease the symptoms. Although one does not have depression to be diagnosed with bipolar 1, it may also be present with depression that lasts over 2 weeks. Next would be bipolar 2. Bipolar 2 disorder is characterized by having both manic and depressive episodes. The mania one experiences with this type is usually less severe than the mania you'd experience in bipolar 1, hence the name hypomania. When one has bipolar 2, one experiences a major depressive episode either before or after one has had a manic break. Next would be cyclothymic disorder. In cyclothymic disorder, one would experience both manic and depressive episodes for 2 years or longer. For children, the same is true except they have to experience both for at least a year to be diagnosed. The mania and depression in this disorder are usually less severe than that of bipolar 1 or bipolar 2. Cyclothymic disorder causes unstable moods, meaning one may have periods of normalcy mixed with mania and depression. And then we have other types. So one may experience symptoms that don't fit into the other 3 bipolar categories. If this is the case, one is considered type 4 or other. This type of bipolar may be caused by factors in one's life that can include drugs, alcohol, or underlying medical conditions. The pathophysiology of bipolar disorder or manic depressive illness has not been well determined and no objective biologic markers correspond definitely with the disease state. However, twin family and adoption studies all indicate that bipolar has a significant genetic component. Next is hormonal imbalances and disruptions of the hypothalamic pituitary adrenal axis. This involved in homeostasis and stress response may also contribute to the clinical picture of bipolar disorder. Next, we have neurophysiological factors. In addition to structural neuroimaging studies that look for volumetric changes in the brain region, regardless of brain activity, functional neuroimaging studies are performed to find regions of the brain or specific cortical networks that are either hypoactive or hyperactive in particular illness. Next, take a look at psychodynamic factors. Many practitioners see the dynamics of manic depressive illness as being linked through a single common pathway. They see the depression as the manifestation of losses. Environmental factors. In some instances, the cycle may be directly linked to external stresses or external pressures may serve to exacerbate some underlying genetic or biochemical predisposition. For example, pregnancy is a particular stress for women with a manic depressive illness history and increases the possibility of postpartum psychosis. Finally, we have pharmacological factors. There is a risk that antidepressant treatment may propel the patient to a manic episode. Drugs that's used to treat depression and drug of abuse such as cocaine increases levels of monoamines including serotonin, noradrenaline or dopamine and can all potentially trigger mania. Now let's take a look at the clinical manifestations of bipolar disorder. So bipolar disorder is characterized by periods of deep, prolonged and profound depression that alternate with periods of an excessively elevated or irritable mood known as mania. Here, at least 3 of the following symptoms must also be present for manic episodes, which are grandiosity, diminished need for sleep, excessive talking or pressured speech, racing thoughts or flight of ideas, clear evidence of distractibility, increased level of goal-focused activity at home, at work, or sexually, and excessive pleasurable activities often with painful consequences. For hypomanic episodes, these are characterized by an elevated, expansive, or irritable mood of at least 4 consecutive days' duration. The diagnosis of hypomania requires at least 3 of the symptoms of mania as stated. The difference being that in hypomania, these symptoms are not severe enough to cause marked impairment in social or occupational functioning or to necessitate hospitalization and are not associated with psychosis. Major depressive episodes are characterized as for the same 2 weeks, the person experiences 5 or more of the following symptoms, which include depressed mood, markedly diminished pleasure or interest in nearly all activities, significant weight loss or weight gain, hypersomnia or insomnia, psychomotor retardation or agitation, loss of energy or fatigue, feelings of worthlessness or excessive guilt, and decreased concentration ability or marked indecisiveness. And this has to be present with either a depressed mood or characterized by loss of pleasure or interest. As for the assessment, examination of patients with suspected bipolar disorder includes evaluation using the mental status examination as well as assessment of the appearance, affect or mood, thought content, perception, suicide or self-destructive behavior, homicide, violence or aggression, judgment or insight, their cognition as well as their physical health. Although bipolar disorder is diagnosed based on the patient's history and clinical course, lab studies may be necessary to rule out other potential causes. Hence, it may be helpful to include a full blood count, ESR levels, fasting glucose levels, electrolyte levels, thyroid hormone levels, BDRL testing, creatinine and blood urea nitrogen levels, liver and lipid panel, substance and alcohol screen, urinary copper levels, anti-nuclear antibody tests, and HIV tests as well. As for imaging studies, consider electrocardiography, which is also known as ECG, as many of the antidepressants, especially tricyclic agents and some antipsychotics, can affect the heart and cause conduction problems. Lithium also can lead to changes such as reversible flattening or inversion of T waves on the ECG. Next would be EEG, electroencephalography. Generally, a routine EEG is unnecessary in the evaluation of bipolar disorder or manic depressive illness. However, for some reasons, ordering EEG in patients with bipolar illness may be appropriate if EEG provides a baseline and helps to rule out any other neurological problems. And if electroconvulsive therapy is contemplated, then an EEG may be helpful. MRI of the brain has a value in the sense that it may pick up any space-occupying lesion or meningeal diseases that may give rise to hypomanic episodes. Always evaluate patients with mania, hypomania, and mixed episodes and those with bipolar depression for suicidality, acute or chronic psychosis, or other unstable, dangerous conditions. The treatment of bipolar or manic depressive illness is directly related to the phase of the episode. So, for example, a person who is extremely depressed and exhibits suicidal behavior requires inpatient treatment. In contrast, an individual with a moderate depression who still can work would be treated as an outpatient. Medications used to manage patients with bipolar disorder include benzodiazepines for acute agitation, antimanic agents such as lithium, anticonvulsants such as carbamazepine and sodium valproate, first-generation antipsychotics such as haloperidol, second-generation antipsychotics such as quetiapine, acinapine, risperidone, olanzapine, fluoxetine, which are antidepressants, and dopamine agonists such as pramipexole. So to summarize, we have looked at the 4 types of bipolar disorder, which is type 1, 2, 3, and others. We have also looked at what are the general causes and pathophysiology to bipolar disorders, which are closely related to genetic linkages, hormonal imbalances, neurophysiology changes, environmental and pharmacological factors as well. We have looked at the clinical manifestations of bipolar disorder, how to come to a diagnosis, and finally approach to therapy. We have come to the end of this topic. Thank you.